Hello friends, this is a case of laparoscopic cholecystectomy for a large stone. There is a 4 centimeter stone in the Hartmann pouch and we will perform laparoscopic cholecystectomy. So, here we are introducing the varus needle through the inferior crease of umbilicus. And this is a disposable varus needle. So, we will do irrigation, suction and hanging drop test. This is irrigation test, suction test, in hanging drop. After that, we will start insufflating the abdomen. So, here we are using the preset pressure 15 and actual pressure, we will wait for reaching the preset pressure and slowly we can see homogeneous distension is started. Now, the pneumoperitoneum is over. So, we will take the varus needle out, enlarge the incision to 11 mm. And the first port will be introduced, that port will be for telescope. So, now the first port is introduced, telescope is now inside, gas is reconnected. Now, the CO2 insufflatant is started again at the rate of flow rate, maximum flow rate is increased to 10 liter per minute, and now this is the epigastric port which we will put just below the G sternum. Initially it should be perpendicular, after that towards the right, and then we will put the third and fourth port. Third port is mid clavicular line, just below the costal margin or just below the fundus of the gallbladder. This is 5 mm, and fourth port will be 7.5 centimeter lateral and below the third port on the anterior axillary line. So, this is the fourth port. After that, patient is head up and right up, fundus grasper is introduced, and this is the Hartmann pouch grasper is introduced, and then surgery will start. So, now inside the abdomen, once we see here, so this is the gallbladder, fundus of the gallbladder is held by the fundus grasper, it is pushed towards the right shoulder. Little adhesion is there, and down there you can see this large stone which is occupying the almost entire Hartmann pouch and it is bulging out. So, in these cases, if you will try to hold the Hartmann pouch, you cannot hold it, and of course, these cases you will get the mucocele of the gallbladder, and sometime if it will press the right hepatic duct then or the common hepatic duct, then it will also called as the Mirigy syndrome, but here it is not pressing the common hepatic duct, but it is a large stone. So, problem is if you will try to hold it, then it will slip and you will not get the cystic pedicle. So, it is always in those situations it is better to remove the stone first. So, for that you should just give the longitudinal incision With the harmonic or hook, you can give the incision over the stone, and first we should try to take the stone out. So, this is a Maryland which is trying to get a good plane. So that we can prevent breaking of the stone. And now this entire stone is taken out. And you can keep it over the momentum of the transverse colon, and this will be waiting later for taking it out. After that, we will do little suction irrigation, and then it is easy to hold the Hartmann pouch. We can see Rovier sulcus there down at the level of the suction, and all our dissection should be above the Rovier sulcus. So, this is the stone. Now, here we are doing the dissection above the Rovier sulcus. The another feature which you are using, that is not Rovier sulcus is down, and then this is the anterolateral traction to do anterior dissection at the level of the body of the gallbladder. We should avoid going near the CBD, and first we should try to open the visceral peritoneum at the level of the angle of the body of the gallbladder with the cystic pedicle. Now, gallbladder is empty, mucus has also come out. So, that is why it is easy to hold and give anteromedial and anterolateral traction. So, this is the posterior window which is forming in between the artery and duct. Here we can see inferior surface of the liver is visible and cystic plate is visible. That is the posterior window. So, that is the one of the boundary of the laparoscopic Calot's triangle is the inferior surface of the liver, and the gallbladder is getting separated. So, the posterior window is enlarged. After that, this is the anterior which is in between the artery and duct. So, this also is enlarged. CBD is down, this is the anterior window, and this is the cystic duct. CBD is down, which is tented little bit, you can see, and this is the CBD, and here is the common hepatic duct. This is the incision which we have given, and we are below the incision, and here you can see duct and artery is visible, common hepatic duct is down, CBD is also visible. This is cystic duct, this is cystic artery. And now, because it is a dilated cystic duct, this is the anterior window and that is the posterior one. So, now because it is a dilated cystic duct, so in those situations, we will tie the extracorporeal knot, that is always better. This is the anterior window, this is the posterior window, and critical view of safety is identified. After that, we are using the extracorporeal knot here, that is the Mishra's knot. An advantage is that even if you do not have a large size of clip, this extracorporeal knot will ligate the cystic duct very nicely, and you will not have any problem. So, this is the suture which is taken out and tying the knot. This is first hitch, this is first wind, this is first lock, then this is the second wind, this is the second lock, Then this is the third wind and here is the third lock. So, this is Mishra's knot and now you will slide it by the knot pusher, and only one knot is more than sufficient because it is a beautiful knot, and the beauty of this knot is that it will not take even the tented CED, it will go automatically to the junction, and dilated cystic duct also nicely can be ligated. So, here it is one knot is more than sufficient and you can see a dumbbell is formed, and knot by default will sleep on the junction of the cystic duct. So, do not worry, there will be no any chance that it will go to CBD, and after that we will apply. So, this is the knot ligated over the cystic duct, and it was a dilated cystic duct. So, always knot is better. The opening here you can see, this is the opening of the Hartmann pouch through which we have removed the large stone. So, after that here we are using harmonic scalpel and the duct is cut above the knot, leaving at least 3 millimeter. Care should be taken that suture is not cut, and now artery directly we are cooking with the harmonic. So, you may do clipless cholecystectomy if you have a harmonic, the artery can be coagulated, however clipping is always appreciated, and during sealing of the artery you should not give any traction. So, now it is over. This little oozing what you are seeing is, that is from the liver bed, that is not due to the any bleeding from the artery. So, it is not a active bleeder, and it is a very thick walled gallbladder, edematous gallbladder, not completely porcelain, but little bit calcification is already there. So, slowly you have to separate it, and if there is some oozing you can do fulcration. So, this is slowly coming out, and we can see there was just a single large stone with the mucocil and edematous thick wall which is coming out by the blunt dissection from the liver. You can do fulguration by the tip of the harmonic or shaft of the harmonic if there is some oozing from the liver. And then after reaching to the last part, the grasper is reattached nearer the liver, and then this is the final inspection you should do for any duct of Laska cystohepatic duct, and then this is the final cut. So, it is finished. After that, in this you should use endo bag. This is a commercially available Indian endo bag, not endo catch from Covidian. This is simple endo bag, but it is also very strong, and it has a silicone ring so that you can hold it, and then endo bag was opened and the gallbladder and a stone was dropped into the endo bag. Because if you will try to not put it in the endo bag, then this stone cannot be taken out, and if you will hold by the stone holding forceps, it may break and it may jump here and there in the abdomen, and it will contaminate the port wind also. So, now this endo bag is opened, it is all wrapped like a cigarette paper. So, you have to first unfold it, and this is the gallbladder. Here Maryland is not able to hold it because of the size. So, you can use a stone holding forceps or claw forceps, that is 10 mm. So, that can hold the stone. This is a stone holding forceps, and then you can put the stone into the endo bag, and after that you may crush it inside the endo bag, so that when you will pull it out, then you do not have to break it by ovum forceps. So, this is the stone holding forceps trying to crush the stone inside the endobag itself. Sometimes these stones are so strong that you may have a fear that your stone holding forceps also sometime breaks. So, now it is broken. After that, you can catch the sleeve of this endobag and it can be taken out with the epigastric port. So, we can see there is no bleeding, there is dry subdiaphragmatic area and more Morrison's pouch is also dry and all the stones are inside the endobag. And the sleeve of the endobag is held by a 5 mm grasper, and now it will be hidden into the cannula and then cannula also will be taken out, and now with the ovum forceps it is crushing, and after that this is final lavage and surgery over. So, thank you very much for watching this video. This was just a simple case of the cholecystectomy.